This is Jim Unland, editor of the Journal of Healthcare Finance, and it's my pleasure to be joined by Alberto Jacir and Damaris Mendoza, two of the four authors of what I consider to be an article that's going to be classic, and that's rare. The article is "The Cost of Care During Times of COVID, Case Study of TDABC and Minimum Utilization Cost Analysis in a Medicare Advantage Population." Now that may sound like a mouthful, but they are going to go through some slides and explain what they're talking about. And I think this particular subject really lends itself to your slides, folks, which you've done really well on. And it's my pleasure, really, to be able to supplement your fine article with this presentation. So with that, I'll turn it over to you all.
Well, thank you. Thank you so much. Well, thank you, Dr. Unland. It's a pleasure being here, and hopefully we can contribute to the literature with this way of analyzing and taking a look at what value-based care is and the capitated payment model. Next slide. So first of all, it's important for us to understand what is value. Value is outcomes over cost. Michael Porter, authors such as Dr. Kaplan from Harvard, very well define value as the best outcomes per dollar spent. And that's the first principle of value-based care, is to understand how you structure the value. Now we move on to the change of paradigms that currently exist. Currently, the vast majority of the healthcare market is fee-for-service. Fee-for-service is basically, as a physician, I get paid exactly for what I do. It doesn't matter how well I do it, it just matters how much I do it. And that has led to lack of accountability, really not taking into account outcomes when it comes to the care provided across the nation. For decades now, there has been an attempt to find other reimbursement models where outcomes are actually brought to the forefront as a better service of care to the patient. And that is where the shift of paradigm happens. You go from volume now to outcomes. And that's where value-based care comes in. No longer are you paid for what you do, but you're paid by how well you do it. And it shifts the risk. The risk now is on the providers, the MDs, the DOs, the APRNs, the healthcare team, to provide good care. And based on that good care is attached monies or financial well-being for the institution. So with this slide, it's very important to illustrate how the market is a lookout for the market from here to the end of the decade. These slides, taken from the Kaiser Family Foundation, stipulates that the projected amount of Medicare patients who are patients who the healthcare is provided by the federal government, 65 and older, and with some exception with disability. There actually is an augmented service that's called Medicare Advantage. That means that besides the bare bone Medicare that patients receive, they can augment their care by paying premium to a third-party insurance company. That third-party insurance company is where this value-based care comes to light, because the reimbursements of these companies to the providers or the healthcare systems are based out of outcomes. Now, just to have a glimpse of how much this market will grow by the end of the decade, they think that over 50% of all patients on Medicare will have a Medicare Advantage program. And these statistics come from the Congressional Budget Office that last year, in the middle of the pandemic, actually brought up these numbers. So these are pretty accurate numbers, and the projections are as accurate as they can be, because the government, which is the largest healthcare payer, is putting their tokens in the basket of these statistics. So we're talking about over 60 million people by the end of the decade under a value-based care model. reason why it's so important for us to understand the economics behind it if we're to survive as a healthcare system. Damaris?
Dr. Jacir just got done speaking to value-based care and the expectation that over the next couple of years, I'd say 5 to 10 years at most, if not very much sooner, we're expected for healthcare to move into this managed care value-based environment. And in this value-based environment, there's a common type of reimbursement, and that reimbursement's the capitated payment model. And basically, in the simplest form, it's when we get paid on a per member, per month, a fixed amount to service a patient. And why this is important? It's important because if you're getting a fixed amount to service a patient, it's important for you to know, well, how much does it cost me as an organization to service that patient? So that when we have these conversations with whoever it is that's going to be providing the reimbursement, whether it be government, organization, or a private payer, that we're able to have an idea of what it costs, and we can then negotiate at a point where we're profitable.
So to better understand what the basic of economics of value-based care, we want to explain further these various concepts. The medical loss ratio, the Medicare risk adjustment, the minimal utilization cost, which we introduce through our research, quality metrics, and controlling costs. So for anyone who wants to understand more about value-based care or a capitated model, be able to understand more how the Medicare Advantage reimbursement works, these are the basic concepts that we believe it is important to understand and have clear. Right? So let's start with the medical loss ratio. The medical loss ratio is determined by the Affordable Health Care Act, put out that for every dollar spent, or every dollar paid for healthcare, 80% of it should go back to the care of the patient, and 20% of it could be profit. Now, that's simplified, but that's the gist of it. The medical loss ratio is utilized in the industry to be able to compare how costly, or to demonstrate how costly or not you manage your patient, or to represent how costly your program is. So ideally, a medical loss ratio, or an MLR, should be between 80 and 90%. If you state that the MLR of your program is 85%, 90%, 92%, there's still some profit margins associated to that. So you're profitable. But if you say the medical loss ratio is 110%, 130%, anything above 100%, at that point, you're at a loss. So the medical loss ratio is utilized to represent how costly or not your program is.
You calculate that medical loss ratio by really pretty much having a good handle on what those expenses are, right? But then we also want to know what the revenue, what do we receive as income for that patient. So that's how that percentage comes into play, and it's calculated. Sorry for the interruption, Dr. Jacir.
No, and that's right. So if you want to be more specific about that, the medical loss ratio, the formula is on the complexity. It has to do with the monies that are reinvested into the care of the patient, including improvement in quality, including in strategies for quality improvement of care. So everything that should englobe that 80% of every dollar paid by the government for the care of that patient. So then we move on to the medical risk adjustment. The Medicare risk adjustment offsets the costly patient. For example, if you have an MLR of 110%, that's not the whole story. The following part of the story is to understand what is the MRA. The higher the MRA, the more represents the complexity of the population of patients you are managing. So the higher the MRA, it tells me that I have a much more complex population, and thus the MLR can be tolerated a bit higher, because a higher MRA actually provides extra reimbursement because of the complexity of that patient. In my understanding, that is to limit cost shifting between the not so expensive. So you can say that the healthy patients will take care or contribute to the economics of the sicker patients. There's an adjustment based on the sicker patients get a higher per month per member, or you get an extra income for the more complex patients. That's why it is so important that when you do value-based care or population health management, which it's all on the same scope of service, to document well certain diagnoses in particular and address them. There are certain diagnoses like diabetes, congestive heart failure, that normally these patients require much more attention, much more care, much more problem solving, etc. And thus they have a denomination that's called HCC. And basically that says that this is a high complexity code. It's a higher complexity diagnosis. And thus that contributes to higher MRA that offsets higher MLRs. And then we move on to the minimal utilization cost, the MUC. This is a variable that we were able to obtain through our research, in which we calculate what is the minimal cost to obtain a set outcome within a capitated model. And that is key, because when you do value-based care and you do population health management, it is extremely important to have a standardized format, a standardized process to manage large populations of patients, which most likely have the same pathologies. As an example, for a diabetic, it is recommended to see the patient 3 or 4 times a year. So if I know the cost of that visit, I can calculate the cost plus the routine labs that I do throughout the year. And then I can have a set number, which is the minimal cost that I need to have monies to have available to be able to provide a certain care for the patient. Now, that is the novel part, because in cost, healthcare in reference to cost, it escapes. It's to a point, is ephemeris. We don't really know what is the cost. And that's where our methodology of TDABC, which is brought in from Kaplan and Porter, really, when utilized in this scenario, helps pinpoint an accurate calculation of the cost incurred throughout a specific visit or visit type. And then based on that is how many times do you do that visit? And then you add to that labs or what other tests that you would consider standard during a serious period of time. Now, Michael Porter specifically states that outcomes is for the whole disease process. But we, for simplicity, we came to an agreement as a research team that the variability of time was taken to put down for 12 months, which is what are these contracts written up for? So for me to measure outcomes from one point to another point in time is that 12 months, because those contracts are of 12 months. So that was why we said, well, outcomes should be measured once a year, and thus the cost of care should be anchored into the variability of that time frame in which we want to see outcomes improve, which is that year of service.
There are 2 additional components when we talk about the basics of economics of value-based care. So we just really focus the first 3 at the very top of the pyramid. There are your financial components, but there are 2 other components that we don't almost always kind of associate. And it has to do with the quality metrics and the controlling cost portion of it. With the quality metrics, there is an economic component attached to that, because based on, just as Jacir stated earlier, the complexity of the patient, there's a monetary amount or monies paid for that. So when you're talking about quality metrics, whether it be in the private sector through a commercial plan, or the governmental sector when you're talking about Medicare and Medicaid, there's the HEDIS quality metrics that we follow pretty universally for what's considered the standards of care on what should a patient have, age, gender, demographic specific for that particular journey of care. And if we can prove as organizations, as providers, that we can provide this care effectively, we are then given the economic incentive or bonus as an addition to our bottom line or the revenue. So in order for us to meet those quality metrics, then it's also very important for us to control the costs. Because at the end of the day, everybody needs healthcare and somebody has to pay for it.
So a little bit, yeah. So back a little bit more for the medical loss ratio, because this is where you could state that the bottom line, the financial bottom line comes from. And as I mentioned earlier, for every dollar, 20% of it is profit and 80% of it goes back to the care of the patient. So by that said, it is important that we understand our costs. In a capitated payment model, you are paid upfront per month, per member. In other words, they already gave you the money. And at that point, it is up to you as a provider, as a system, to provide the care. Now, if I already have a set amount of money in my account to take care of these patients, the least I have to know is how much does it cost me at a minimum to provide a level of care, a good level of care with good outcomes. And that is the best part that we want to talk about here today, because that is from our standpoint, that's novel, that is new. To be able to calculate, a system to calculate, and then using that calculation in one way that provides value to the institution, obviously then you translate to good quality to our patients. So for example, in a per month per member, right, you get paid $100 per month per member as an example, right. $1,200 per member per year. Based on the 80-20 rule, I have $960 to spend on that patient in care. That's the bottom line. That's how we start the conversation. And then we figure out how much are we really spending on the care of the patient. Next.
So we started this research by kind of mapping it out. Well, what were the steps in servicing a patient, beginning to end? And we started to include how long it took in minutes for each person who had a touch point with that particular patient for that particular encounter, so that then we can later use that the unit of minutes to calculate the per minute cost for that particular role through the continuum of care. So you start, the patient comes in, they make the appointment, they access our patient access representative or customer service representative. In this particular scenario, we did a telemedicine visit because we were talking about COVID. We had a different vision when we were going to start this, but then COVID hit and we had to kind of shift gears into telehealth. We started from the very beginning. How long did it take to make this appointment? When the actual day of the appointment came, or even before then, what pre-work needed to be done even before the patient came in? What happened when they actually logged into the Zoom meeting to connect with the provider? What questions were asked? What were the evaluations? Who touched them? And whether it be a medical assistant or a customer service representative or a nurse practitioner or physician, we timed each and every one of those touch points. And so this process map represents those touch points. Then we moved on to what we call the time-driven activity-based costing, the TDABC portion of it. And this provided us with the dollar amount. So we knew that through our process mapping, if you look at this particular slide, it takes 12.5 minutes, give or take, and these are averages, for the patient access representative interaction with the patient. It takes approximately 15 minutes for the medical assistant beginning to end interaction with the patient. And then depending on if the patient was seeing a physician or MD or a nurse practitioner, 20 minutes on average for each. And then on the back end, we've talked about reimbursement. We talked about MRA. We talked about HCC scores. The coder does all of that behind the scenes. So what we did here is we kind of calculated what were the expenses based on salary and overhead charges for each of those different roles. We then went ahead and calculated the capacity in minutes. And basically this was using the basis or the assumption that an employee worked 20 days per month, 12 months per year, 240 days per year at 8 hours per day. And so that came out to 115,200 capacity minutes. Simple division gave you the capacity cost rate, which is at 77 cents per minute. And then since we knew, let's say we're going to stay on the patient access representative, that the patient access representative was with the patient for 12.5 minutes, that equates to $10. And we did that systematically through the different roles as they touched the patient so that we knew, what it would cost for that. And then we had the sum at the very end.
So it's very important to understand that for this to happen, for you to do this analysis, you have to make sure that you have a standardized process. The processes have to be standardized and with very little variability. And once you start off with that, at that ground level, then you can time these processes and then take average of standard deviations. But let's start with that. Now, how Damaris explained, we were able to break down the cost per minute of each one of the individuals that added value to the patient's visit for one visit or telemedicine visit. Then we did some adjustments for in-person. Now that we knew how much it costs and timeframes, and now we can actually start, having pretty good assumptions of in-person visits. And then based on salary differences, then we can go ahead and calculate what it costs for an MD or DO and for an APRN. Now we have this. Now we know how much it costs for a visit with MD telehealth, MD in person, APRN telehealth, APRN in person. Okay. And now we are able to obtain the cost of specific labs that we, as an example, we brought in together as basic labs once a year at a minimum. Remember, this is a minimum. You get a full blood counter, a CBC, a complete metabolic counter, CMP, a thyroid function, a urine analysis, a cholesterol level, and an EKG. Again, this is an example. We're not defining the best practice, but putting an example on how to calculate the possibility of a best practice as determined by the institution who decides to put this together. Now, when you bring all that together, is where you obtain a minimal utilization cost. So in other words, I know how much it costs. I can project how much it costs per patient to provide a standard level of care in 1 year. So we go back to our example. If I get paid $100 per month per member, at the end of the year is $1,200. Based on the calculations on the right slide, on the right-hand slide, on the right half of the slide, better said, sorry. Basically, the costs are at $1,600. That means that my medical loss ratio is at 134%, when in fact, based on the per month per member, when you total it through the year, an 80% medical loss ratio is $960. I'm at a loss. And that is the key, because now you can stop in the middle of the year and say, where are we? How much are we spending on the patient? What is our medical loss ratio? Let's look at our processes. Where is the waste? You can do Lean Six Sigma analysis to better improve the process, try to decrease those costs, to try to adjust your medical loss ratio. You can see if you're doing unnecessary amount of care or lack of, and then you can also discuss the reimbursement rate, stating for appropriate level of care, a minimal utilization cost for a patient is so much. But now with the methodology of TDABC applied with this method and based on our research, we are able to grasp a minimal cost per patient to provide a standard level of care. And of course, there's a lot of malleability in this. You can add tests, you can take away tests, but at least it gives you a starting point to be able to project the margins and then provide a true the true denominator from the value equation, which is the costs.
So earlier we talked about TDABC and we talked about minimum utilization cost and how they serve as those monetary benchmarks for the cost of care for a specific population given certain constraints. It's necessary for us to be able to do that because everyone needs healthcare. But most of us have limited resources. And even if we had unlimited resources, we would prefer to keep those resources for ourselves and be healthy and not spend those resources in healthcare if we didn't have to, right? Another reason why it's important for us to be attuned to and be aware of per capita costs is because we're being held accountable by the payers for the costs for these providers. So we need to be looking, like Dr. Jacir said earlier, are we effectively doing this? Are we efficiently doing this? Are we being wasteful? Are we ordering extra tests that the patient doesn't need? Does the patient really need to be doing that in the inpatient setting? Can they be in an outpatient setting for this particular test? And so being the good fiduciary of our fund, of our funds for that particular patient. So we accomplish this by a few different ways. First, process review. You have to sit there and kind of map out how is it that you're doing it today and how is it that you think that you should be doing it in the future. Then you need to actually look at your financial indicators. What are your key performance indicators? What are your expenses? What's your revenue? Where am I performing well? Where could I improve? And what are some of the drivers driving that expense that I have control of? So, we're NCI designated institution. So because with that NCI designation comes the higher acute patients with a cancer diagnosis. Some of the things associated with the treatment and the care for a cancer patient will be costly. And some of those treatment modalities you don't have control of, but you do have control of other things. You have control of whether that patient, to prevent a hospitalization, you perhaps need to see that patient in an outpatient setting with a primary care provider or a specialist more to prevent a more costly hospitalization later. And that may mean on the front end at a lower cost of care, managing that patient to then prevent that higher cost ticket of an inpatient admission. And then, of course, looking at your clinical performance. You want to also think about, well, how are you perceived? Is the patient satisfied with the care that they're getting? Are the payers satisfied with the quality of care that we're providing to their patient population? And they do this through a variety of different scorecards, different metrics that we have to meet. And we have to review those things and act upon based on our performance on those things. So in a nutshell, it's important for us to not only be thinking about, at the very beginning, we talked about the fee for service, how do we get these patients through the door? We also have to be thinking about, well, how do we get these patients through the door and we service them in the best manner and providing the best quality care that we can through their journey, their episode of care, being cost conscious. Dr. Jacir, I'm going to give it to you for wrapping up final comments before we close our.
I do think that it's very important that we understand that within the framing of value-based care and capitated payment model is the opportunity for competition. So as Damaris pointed out, there are some visual scores where a patient could compare one institution from the other or for one insurance company from the other. And that's very important because value-based care, as we've talked here, is about capitation, and yes, is to improve outcomes at decreased costs. But at the end, what really drives the healthcare system, in our view, is the competition between institution A and institution B. And if now Medicare and Medicare Advantage has done a great job in initializing benchmarks that patients can use to choose where to get care within their region, within their city, within a state, for example, that plays into the role of value. And so it's not only the fact of the low cost and best outcomes, but also how that translates to the consumer, promoting competition. And with competition may very well be the key to resolving the conundrum of the American healthcare system of it being so expensive. So with that, Dr. Unlin, any questions?
I want to thank you very much for an excellent presentation that augments what is already in an excellent article of the Journal of Healthcare Finance. In anything we write about this, we will put a link to your article. And this article, by the way, is open source. No one needs to sign in or subscribe to anything in order to read this article. It's on a very important subject matter. I'd like to thank the two of you and your other two co-authors and encourage you to keep talking about this. Hopefully through this presentation, people will get a broader idea and then be able to read the article or have already read the article and gain more knowledge because of your perspectives that you gave. And thank you both for taking the time to do this.
Our pleasure. Thank you.
My pleasure. Thank you, Jim.